Hello, I'm Bethany Samuelson Bannow, Deputy Editor of ASH Clinical News, and we are here on site in sunny Orlando at ASH 2025 talking about some of the wonderful science at this meeting. And so right now I am here with Dr. Gloria Gerber, an assistant professor at Johns Hopkins University and expert in PNH. So now we're going to talk about abstract 1118, which is a novel antibody to help again, block the complement cascade, as many of our treatments do. And this is a follow-up, right? An 8-week follow-up safety profile from previously reported data. And we'd just love to hear your insight, Dr. Gerber, as somebody who treats PNH, about how this therapy fits in with what's currently available and might be coming down the pike.
Yeah, so this is a relatively long follow-up of the phase 2 trial, as you said, of treatment-naive patients, so they were followed for 2 years, and then we have an additional 8-week period to look at safety data and actually how long this agent lasts. So it's delivered. It's interesting because the antibody both targets factor H and C5, so you're getting both inhibition of the terminal pathway, but also kind of upstream complement pathways. So factor H is a soluble complement regulator that binds the cell surface and inhibits the alternative pathway, so that amplification loop of complement that's so important in PNH, but also has some inhibitory effects on the classical pathway. So you're getting that dual inhibition in this molecule. And I think what's exciting about this so we have one other dual therapy that's available. When I say dual, I mean inhibiting both the alternative pathway of complement and the terminal pathway. And that currently is our currently approved C5 inhibitors, so things like ravulizumab, eculizumab, crovalimab, in combination with danicopan, which is a factor D inhibitor, so that's a protein in the alternative pathway. That factor D inhibitor, danicopan, that's approved as add-on therapy to the C5 is oral, but it's 3 times a day. So that could certainly pose a challenge to our patients. Plus, if you're on ravulizumab, let's say, which is what the majority of PNH patients are on when we think about C5 inhibition, that's an every 2-month or 8-week IV therapy. And so what's nice about this option is it's another treatment modality, so subcutaneous and every 2 weeks, but you're only having to take kind of one agent versus the 2 to have the dual inhibition. And so I think that's exciting. And the other thing about this is because it's subcutaneous, and even in the 8-week data that they did at the end, it suggests that there's complement inhibition potentially beyond that 2-week window, is that, again, factors like compliance, having a stomach virus where you throw up all your oral medications and you have this complement amplifying condition or food poisoning or whatnot, become hopefully less of a factor. And in this trial, although small, patients attained, I think about a mean hemoglobin in the 13s. So most patients did attain that, a normalization of the hemoglobin. But I think more importantly than normalization of the hemoglobin, at least in my mind, is in the 2 years, there were only 2 breakthrough events. And we know when patients break through on monotherapy of an alternative pathway inhibitor, these breakthrough events, because you have a large PNH clone, because you're not eliminating your PNH red cells through extravascular hemolysis, so your PNH red cell clone will mirror that large white PNH white cell clone. You can get, in the setting of a complement amplifying condition, again, pregnancy, surgery, infections, vaccination, pretty massive hemolysis in some cases with significant hemoglobin drops. In certain cases, I've heard of kidney injury from that hemoglobinuria, et cetera. And so, again, in this setting, in 2 years, there were only 2 breakthrough events. And for me, that's exciting and reassuring when I think about the safety of my patients in the long term.
Yeah, that's great. And then another thing we think about in safety of patients with PNH is, of course, thrombosis.
Sure.
And so we have a couple of years here. And so what are your thoughts on where this fits in patients maybe who presented first with thrombosis, or that's a big concern for them?
Yeah, so there were no thrombotic events or, vascular events that were reported as part of this abstract. Overall, in PNH, we have to remember that thrombosis is complement mediated, right? Because before we had complement inhibitors, thrombosis is what patients die about. So I love that you're asking about that, because that's the most important thing. That's the source of mortality in PNH, right? But also we know anticoagulation really doesn't work, right? So once we started complement inhibition, we found that these patients were no longer dying of thrombosis. And actually in our group, we stop, if a patient is well controlled on complement inhibition and they've been treated for that acute provoked event, we actually will stop anticoagulation, or at least have discussions with our patients about the risks and benefits of that. So I think these are important questions. I would expect with this agent, and I think the 2-year data bears this out, that certainly, we're going to see that same control of thrombotic events. I think you ask an important question about the, initial management of thrombosis. So there is that PNH patient who you're going to diagnose in the acute setting with, a splanchnic vein thrombosis or cerebral venous sinus thrombosis, and that's what's scary. And I have to be honest, I'm not sure I would use this drug as the first drug, just because it's subcutaneous, right? And you want that immediate complement inhibition. And maybe that's there, but in my mind, we don't per se have, with the subcutaneous delivery mechanism, that gives me some pause. We don't have the data, whereas we know, other C5 inhibitors like ravulizumab, eculizumab have kind of that immediate onset effect, which is what you want in the setting of thrombosis, right? So I think certainly for long-term management of patients who have thrombotic events, this data is incredibly reassuring. We need longer-term follow-up, but we have 2-year data, which is pretty good. But in the acute setting, I still think I would defer to kind of these more studied agents.
That's so insightful. Thank you. And then finally, what are your thoughts on the rates of infection that they reported? Because that's another big concern in patients on complement inhibitors.
Yeah, I think that's also a great question, because we had this fear initially, especially with dual inhibition, that we were going to see these terrible infections. And that really hasn't borne out when we think of, danicopan with a C5 inhibitor, so that dual therapy we already have available. And I think, again, that's because the immune system in PNH patients is developed, so it's not like a person who has a congenital complement deficiency, right? In this study, let's say about 30-ish% had infections like COVID-19 or upper respiratory tract infections, which I think is going to be expected, frankly. And again, we don't see this extreme, extreme uptick in breakthrough hemolysis events from the infections, right? So again, the infections we're most concerned about, like meningococcal infections, we did not see in this study. And I think it will be very similar to the other complement inhibitors that are on the market. But I personally don't believe there's an increased infection risk with the dual inhibition.
That's great. What an exciting time to be a PNH scientist and even a PNH patient, insofar as there's more options coming down the pipe.
Yeah, I think that's the most important thing. I mean, right, we had one agent for so many years, which was great because before that there was nothing.
Yeah.
And then now, we have 6 FDA-approved complement inhibitors. So it's an incredibly exciting time. I think as PNH physicians and providers, we're still learning exactly what inhibitor is best for what patient. And I think patient weigh-in is incredibly important there, understanding things like compliance, what works best for their lifestyle. What are their fears? Do they prioritize longer-term data versus, what symptoms they're having, higher hemoglobin, things like that. So I think a lot of this is very patient-centered in conversations with your patient. And for me, the most exciting thing is that we have different options and choices for our patients, right?
Yeah. Yeah, it's incredible. Well, thank you so much for sharing your insight with us, Dr. Gerber. And thank you for joining us for our recording again here live on site at ASH 2025. And you can look forward to more great coverage on our website as well as in our January edition. Thanks for joining us.